Welcome, everyone. We have the pleasure of having two sessions this afternoon regarding transplant. Our first session will be transplant for adults, looking at aplastic anemia, MDS and PNH, and then we'll have a session about living well during and after transplant. My name is Lee Clark, and I'm Director of Patient Services, and I'd like to thank you for joining us today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers who have supported our conference today. Immediately following the presentation, there will be a question and answer session. If you're participating online, please feel free to submit your questions at any time during the presentation using the Q&A icon in the engagement panel on your right. To submit a question or a comment, just type in your question in the Q&A window and hit enter when you finish typing. We'll do our best to get to all questions today. When asking questions, I do ask that you do two things to help me manage the incoming questions. First, please submit your entire question all at the same time. Second, please do not share private health information in your question. Our speakers cannot answer any specific questions related to your personal health care. We have the pleasure of having two specialists today. Our first specialist will be Dr. Brian Randolph, and Dr. Randolph is an associate professor and the director of cell and gene therapy at the University of Tennessee Health Science Center, Division of Hematology and Oncology. He specializes in the care of patients with blood cancers with an interest in leukemia, myeloproliferative disorders, myelodysplastic syndromes, and high-risk multiple myeloma. He joined the faculty at the University of Tennessee in December of 2019 and has practiced in the field of hematology oncology since 2009. Dr. Randolph joined the faculty at the University of Tennessee to become part of a team of experts looking to find a cure for blood cancers. He believes that the road to find a cure is through the combination of clinical trials, scientific research, and treating the whole person while also empowering patients with the knowledge and understanding of their disease and their treatment options. Our second expert today will be Dr. Salil Goorha. He is a director of the Baptist Cancer Center Malignant Hematology and Transplant Program in Memphis. He specializes in hematology, oncology, and internal medicine. He joined the Baptist Medical Group in 2018. Dr. Goorha attended medical school at the University of Tennessee Health Science Center, completed an internship in his residency at the University of Utah School of Medicine, and completed fellowships at St. Jude and the University of Tennessee. With that said, it is my extreme pleasure to welcome both of our experts. Thank you, Dr. Randall. You're going first.
All right. Well, thank you very much for having me. It's an honor and a privilege to be here. Thank you to Dr. Thoda and the MDS Society for the invitation. This is definitely a part of my mission, which is that I feel patients and their caregivers need to be educated and aware of their options and have that opportunity to really approach us as the providers to get answers to their questions that they may have. Today, I'm going to focus on adult patients and using transplant as a modality for treating aplastic anemia, PNH, as well as MDS. And so I'm going to go through some basic background information first, but I'm going to move fairly quickly through that because I believe you had a lot of that in your earlier talks through the day, and then try to focus more at the end on really the process of transplant itself. So bone marrow failure syndromes is what we're really talking about. And it's this nice spectrum of diseases, basically, that ranges anywhere from over here on your left, the autoimmune diseases like autoimmune hemolytic anemia, over to your more malignant conditions or pre-malignant conditions, even called myelodysplastic syndromes, which have that greater tendency to eventually transform potentially into acute leukemia. These range on a spectrum that we look at as being more of an autoimmune process in the case of aplastic anemia versus more of what we call a clonal disorder, meaning if you think of clones where you're making cells, they're just like one another and they start crowding out the good cells, that's where we start thinking of myelodysplastic syndrome or MDS, which is part of the reason we feel we see more of that shift towards leukemia in that population is because of these mutations that we find. And there's also a pretty clear age pattern or distribution with these diseases, with aplastic anemia really being a disease more in the younger patient population. Peak incidence here you could see occurs around the age of 10 to 20 versus your myelodysplastic syndromes that tend to peak later in life. So it tends to be a disease of the older patients and particularly over the age of 50. So let's start with aplastic anemia. So what is aplastic anemia? So it's kind of two things. One is having low blood counts, so what we term pancytopenia, and then that persistent absence of cells or aplasia within the bone marrow. So we call it an empty marrow. So if you have low blood counts in the blood and an empty bone marrow, then we start thinking about aplastic anemia. And then the criteria for that to be considered, we tend to think of it as being severe or non-severe. And so in the severe case, we're looking at basically how low are those counts. You also have to take into consideration the manifestations of those low counts as well. And so for severe aplastic anemia, we like to see two of the three criteria where you have a neutrophil count, which those are what I call the good infection fighting cells. So if that's less than 500, or your platelets are less than 20,000, which are the cells that help you clot. So you tend to see more bruising and bleeding issues in patients with low platelets, or reticulocyte counts, which are kind of they're the baby red blood cells. So if those are high, that means you're trying to make more of your red blood cells. So you have two of those three plus that empty marrow, and on the pathology reports that you might pull out of your portal, you'll see something called cellularity. And so the cellularity oftentimes is going to be less than 5% in someone with aplastic anemia. And so that empty marrow is what we're looking for there to call it severe aplastic anemia. And then the clinical conditions, obviously, if you have low white blood cells, then you're more prone to infection and fevers that can be associated with that. Also fatigue from the anemia, as well as low platelets, and then bleeding because of the low platelets. So this is just a very simple algorithm, just the very first step in what we're thinking about in terms of how to treat or manage patients. So the first question we're kind of asking is this severe or is this not severe? So the not severe are the patients that we then start asking, well, are they transfusion dependent or not? And so if they are requiring transfusion, then oftentimes that's where we're going to start looking at treatment. If they're not severe, but not requiring transfusion, for some of those patients, we can actually watch and wait. And so, you know, any treatment is not without potential risks. So we're always trying to balance that risk and benefit there. And then if you have severe aplastic anemia, then more than likely you're already transfusion dependent or you're already having infection complications. And so these patients are typically, and you have a higher risk of progressing. So therefore, these patients oftentimes go straight to treatment. I'm not going to go through this in detail, but this is just to show you that we have an even more intricate or complicated way of looking at things. I think the bottom line here, when we start talking about management and specific treatments, it divides into two categories: immunosuppression versus allogeneic stem cell transplant. So at the top, what they're really telling you here is if you're young and you have a matched sibling, a brother or sister that's a full match, then we're probably going to recommend the outcomes tend to be better if we go forward with stem cell transplant. Versus if you're an older patient, over 40 in this case, or you don't have a matched sibling, and particularly if you have both of those, you're older and don't have a match, then we're more likely to go forward with immunosuppressive therapy first, with transplant reserved for further down the line. And I'm going to go into that in a little more detail. This algorithm extends further. So let's say you get one treatment or the other and you go into a remission. In particular, you get immunosuppression and you go into sort of a remission where your counts are good, you're not requiring transfusions, not having those infections, but then you relapse. So now we have to ask ourselves two things. Is this just aplastic anemia that's relapsing? Or is this progressing? Are you developing mutations and those cells are changing and trying to move more towards the myelodysplastic syndrome that we'll talk about? And in those cases, if it's a relapse of aplastic anemia, oftentimes we will re-challenge with immunosuppressive therapy, but then transplant oftentimes becomes a part of the picture down the road as well. If it's clonal evolution, we call it, meaning that your cells are starting to become more like myelodysplastic syndrome or leukemia, then we start thinking more about transplant earlier on. So this was a paper published back in 2007, and it really kind of asked the question that we're always asking, which is better? Should we do transplant first, or should we do immunosuppressive therapy? And so just a little education on these graphs that they'll come up periodically here. The flatter and the higher the curve, generally the better. The lower the curve or the more it slopes downward, then typically that means there's a worse outcome. And as you can see here, the outcomes were fairly similar actually between these two groups. So they tried to pare down, and this is a complicated chart to look at, but I think the easy thing to do is to look at blue versus red. Blue means that the patients in the groups of age versus their neutrophil count did better with transplant. The red means that they did better with immunosuppressive therapy. So if we kind of group that, basically what you see is that younger patients with worse disease, meaning lower counts, tended to benefit more from transplant early on. Versus when you go to the opposite end of this curve or this graph, you're going to see, or this chart, you're going to see that those patients that are older, so this was 50 years old, for example, with a reasonable neutrophil count of at least 500, those patients tended to benefit from getting immunosuppressive therapy first. And then obviously our world doesn't live in textbooks. So most of our patients fall somewhere in this middle where we're always having this constant dialogue back and forth between their primary oncologist and the transplant doctor of what's the right timing to think about transplant. This is just to show you that over time for transplant outcomes have improved. So if you look just at overall survival at 10 years, we started in the 1970s with a survival of only about 44%. And that has come up now for all comers with aplastic anemia to about 78%. Now, the issue that still lies there is when you start stratifying that by age, you see that your older patients, particularly here over the age of 50, still aren't doing as well. So only about a 43% survival versus 88% for those that were less than 20. So that's a fairly common theme we actually see in oncology. And that's one of the points that I'd like to drive home here is that there's still a lot of work to be done. And one of the statistics that always catches my eye is how many pediatric patients and children go into clinical trials versus adults that don't. And so we've got to do better at accruing diverse populations into these clinical trials so we can understand the biology better and get better treatment options, because 43% survival is not acceptable. We've got to do better. So what's happening with these patients? What you can see is one of the beliefs or one of the theories here is when you look at this graph and compare age, the outcomes for these patients or the causes of death tend to jump up significantly for graft versus host disease, which we'll talk about later when we talk about the process of transplant, and then rejection of your cells from the donor. And so when you get to the age of 40, you're jumping up pretty significantly in that number. So we think that's a big contributing factor to why adult patients may not be doing as well. Now, survival for unrelated donors. So all of that data is assuming you have a matched sibling. So then the question became that, you only have a 1 in 4 chance that you're going to be a match with any one of your siblings. So then what if we use an unrelated donor? And surprisingly, actually, the data has come out to look pretty good there. So about 76% at 3 years for overall survival that we're seeing for adults getting an unrelated donor transplant. Then let's go the step further. I'm going to mention it later how if you're African-American, if you're Hispanic, if you're from any of those minority groups, your chances of having an unrelated match are also fairly low. And so they start looking at not only unrelated donors, but also what you call haploidentical donors, which is going to be your half match. So a couple of things with unrelated donors in general, these graphs are intended to show you where they looked at, does it make a difference if you're a full match versus a mismatch from your donor? And so we will sometimes do transplants in patients that are mismatched by one antigen. And just to explain that better, HLA, which I'm going to get into later, is the molecule that we're looking at in terms of determining a match. So it's not about ABO, what you hear about with red blood cells. It has to do with your DNA match. And so we look at these genes at A, B, C, and DR are the main 4 that we're looking at. And so you get one set of genes from mom, one set of genes from dad. Therefore, you have 2 A's, 2 B's, 2 C's, so forth. And so the standard of care currently remains to have an 8 out of 8 match. There's also what's called DQ, which is another one of those molecules that we look at. So you may hear people say, you've got a 10 out of 10 match, even better. So the standard of care is to have an 8 out of 8, but we also will look at 10 out of 10. In this particular trial, what they considered a mismatch was only patients that were mismatched by 1. So basically 7 out of 8 mismatches. And so even with just one antigen mismatched, obviously what they saw was a significant difference here. So a survival of about 78% at 3 years if you had a match versus 58% if you had a 1 antigen mismatch. And then some of that was likely attributable to what was the higher rates they saw of acute GVHD. And then what's not listed here is there were also higher rates of infection. And then there's also slightly higher risk of rejection as well. Interestingly, though, what was surprising to a lot of us is that the difference in chronic graft versus host disease, which I'll describe later as well, was not that much different. This was a study that simply looked at what are some of those factors in the mismatch or in an unrelated donor that put you at higher risk. And so what they found is they looked at 3 main things: your age, they looked at the time from your diagnosis to when you had the transplant and whether that was over 12 months or over a year or not. And then they looked at the presence of that mismatch. And what they found is if you only had one of those risk factors, your outcome was still fairly good, versus if you had 2 to 3, your survival outcome was likely less. And then they took this out of a French population and they validated it in a broader database of broader European database. And then lastly, this is what I was speaking about with the haploidentical transplant. So the half match. So basically you're like 4 out of 8 or 5 out of 10 matched with usually a child and a parent or your siblings that you should have a half match with. And so this was a study that basically showed us that it is feasible to do haploidentical transplant, because this was very surprising, but the overall survival was 100% and 86% in these patient populations. And the biggest surprise to this at 32 months, so it's early, so just over 2 years, but the surprising thing was that the relapse refractory patients were the ones that seemed to benefit the most from the haploidentical transplant. And then one of the controversies that you may hear if you're an aplastic anemia patient and you're having that discussion around transplant is, where did the cells come from? So in the original days of transplant, all stem cells were taken from the bone marrow itself. And so that meant going to the operating room and having your donor going to the operating room, being under general anesthesia, and then having all of you would be familiar with bone marrow biopsies. So it's like having 100 or 200 bone marrow biopsies done all in one procedure. So naturally you're under anesthesia. There is some risk, the risk of anesthesia and so forth. And so this debate had come up about, does it make a difference if we collect the stem cells from the blood versus collecting them from the bone marrow? And this study actually showed that in children, there was a significant difference. It was actually, they were twice as likely to do poorly if they had peripheral blood stem cells versus bone marrow. In adults, they actually did not see a statistically significant difference between the two. So it's very controversial. Should we go with bone marrow or should we go with peripheral blood? Generally speaking, we adopt a lot of our practices from the pediatric population. And so therefore, we still tend to consider bone marrow to be the source of choice in this case. And a lot of that also stemmed around the incidence of chronic graft versus host disease, which again, in children, they showed a significant difference. They did not have a statistically significant difference in the adult patient population that they defined as being over 20 years old. So shifting gears a little bit, to a different disease, the paroxysmal nocturnal hemoglobinuria, so PNH. So I tend to think of in the transplant world, a lot of times PNH falls to our world because the patient already has an underlying aplastic anemia, and then they happen to find this clone of PNH in the process. But the reality is there's actually different variations on the theme of PNH. It's all the same disease. It's a rare bone marrow failure disorder. It's characterized by this hemolysis that is occurring, and that hemolysis often can lead to blood clots or thrombosis as well. And so it's the result of this gene mutation that has occurred, the PIGA gene. And what that does is it basically makes your cells more susceptible to something called complement, which is what then triggers that whole cascade of destroying your blood cells, so to speak. And then that destruction of the blood cells leads to more free radicals, free hemoglobin, and so forth that irritate, if you will, the lining of your blood vessels that makes you more prone then to blood clots as well. And then along with that, you'll see oftentimes bone marrow failure with low blood counts as well. And so when it comes to transplant and PNH, overall, when you take all comers, the outcomes look fairly good, about 68% 5-year survival. But then when you start looking at, well, why did we do the transplant? It gets a little bit trickier. If the person has only a recurrent hemolytic anemia, meaning they just are anemic, low red blood cell counts that keep occurring and mainly because of this PNH, they actually do very well, it looks like, with transplant. But the majority of the patients that we'll see, they get referred for transplant for PNH is oftentimes because they also have this aplastic anemia. And as you can see, those patients did not do quite as well in terms of their survival. And then if you're transfusing or if you're transplanting them because of thrombotic events, so recurring blood clots, those patients did even worse in those studies. And so this was a very complicated breakdown of trying to find reasons for that. And basically what they found for those patients that are being transplanted because of recurring blood clots, the bottom line that they found here was that the patient population that might benefit actually would be those older patients, so 30 years or older, who at least had a 3-month gap between the time that they were diagnosed and the time they had their first blood clot. And then also looking at transplanting for aplastic anemia, what it showed here was that difference of the patients not doing as well with transplant as getting other therapies, which goes back to that table I showed you where older patients tended to do better with immunosuppressive therapy first. So all of this kind of rolled into some algorithms that we look at. This is a complicated diagram where the bottom line is really the top of this. The real question we're first asking is when you get diagnosed with PNH, do you also have aplastic anemia? Or if you have aplastic anemia, do you have PNH as well? And so then once we answer that question, that kind of stratifies you into some of the newer therapies for PNH versus, which is where we target that complement. So we try to shut down that process of the cells being destroyed versus replacing your bone marrow essentially in your immune system with a transplant. So these are some recommendations that have come out of some of these studies that have been done looking at who gets the better benefit, so to speak, out of transplant. And generally what they're saying is that PNH and BMT, bone marrow transplant, is indicated in those patients who have progressed to a myeloid malignancy, so MDS or acute leukemia, or those who seem to evolve into a bone marrow failure syndrome such as aplastic anemia, even while on eculizumab, which is the anti-complement drug that's standard of care. It's not recommended in those patients generally who keep having blood clots despite taking eculizumab or the complement inhibitor. And it's also generally not recommended for that higher percentage of patients who have persistent anemia despite being on eculizumab. And it's just based on the fact that they've seen worse outcomes for those patients going to transplant. Overall, the estimated mortality is about 30%, and that's primarily due to, and mortality meaning basically the deaths or rate of deaths is about 30% from transplant in PNH, and that's primarily due to graft versus host disease and infection. So the last disease to talk about is myelodysplastic syndrome, and then I'm going to really just get into more of the mechanics of transplant to help walk through that. And so myelodysplastic syndrome, MDS, it's myelo meaning bone marrow. Dysplastic means the bone marrow looks abnormal or funny. syndrome, meaning there's some pattern that's there. And so the characteristics of that syndrome are the low blood counts or cytopenias, as well as having that abnormal looking bone marrow. And then typically we're also looking for some type of clone or mutation in the DNA, so changes in the DNA. And those patients tend to have a higher risk of transforming to acute leukemia, with leukemia and complications of the low blood counts being the main causes of death. So the goals of therapy in MDS, there's really kind of 3 different things that we try to do. If we're trying to cure the disease, really transplant is the only proven cure. But then if we need to just improve the natural history, so in particular, you have a patient who has maybe a lower risk disease and doesn't really need transplant yet and can live a very long life without a transplant, then we want to improve their natural history, which is, taking away the need for some of the blood transfusions. So improving their blood counts, ideally improving their survival, and then also hopefully delaying the transformation to leukemia. And then the third is just symptomatic support. And that's where you're giving blood transfusions or you're using what we call growth factors. So those dreaded shots, the Neupogen and the EPO shots that we may give as well. And then antibiotics when people get infections to treat those infections. So how do we do overall with taking care of patients with MDS? So the first is to look at these, what we call hypomethylating agents. So this is the chemotherapy, if you will, for MDS, this class of drugs called hypomethylating agents. And what I like to think of when I think of what that drug is doing is that this MDS process is basically where you've shut down the normal maturation of the cell. And so I think of it for example, when a woman's having a baby, the baby goes through various phases before it's mature enough to be born. Well, your blood cells do the same thing. They mature within your bone marrow, and then once they reach a certain level of maturity, they can be released into the bloodstream to do their work. And so in the case of these hypomethylating agents, you're trying to reverse that process so the cells can now mature like they're supposed to and be born into the bloodstream to help your count stay up. Well, when we look at azacitidine or Vidasa is one of those drugs, there was a large trial that was essentially done looking at that. And when we start looking at overall survival, the outcomes start out pretty good, but as you get further and further out, you can see, remember I told you as those curves go down, that means the outcomes are getting worse. And so those curves just keep going down. And so if we want to look at 3 years of survival, 3 years of survival on those medications is only about 25 to 30%. And so that's where we're still looking for more options. Now, on the other hand, if we talk about transplant, this was one of the largest studies that was done. It was looking at older patients in particular, ages 50 to 75. They looked at patients who basically had what we call intermediate or high risk disease. And they were looking at whether they benefited from transplant or not, but it wasn't a randomization. It was based on whether you had a donor or not. So those patients who did not have a donor basically received whatever other therapy was available for them, either supportive care or one of those hypomethylating agents. And then the donor arm are the patients that actually went through transplant. And so you can see that your no donor arm did about what we said in the last slide. So that 25 to 30% survival was about 26%, versus we basically doubled that almost with transplant and brought that survival up to almost 50%. So that's where the role of transplant in MDS really comes in. Now, the catch is figuring out who is the right patient, the right time, and so forth to do the transplant. And so that gets to be a little bit trickier. This was where they broke it down into different subsets. And the one thing that they did find is that regardless of the subset you fell into, if you fell to the right of this line, so over here, you tended to have a benefit from having a transplant. And so all subgroups had some degree of benefit. What they also showed as far as complications of transplant, so there's this transplant-related mortality. So that's dying because of some complications specific to the transplant. It was only about 7% at 100 days and about 15% at a year. A lot of that was related to severe acute graft versus host disease, in which we've now found more and more ways to circumvent that and improve those outcomes. And then also looking chronic graft versus host disease, so graft versus host disease that occurs later in the process, and that was about 16%. Now, despite having higher incidences of graft versus host disease, or about a 16% incidence, the quality of life scores were still fairly similar between the groups, though. So to kind of sum up MDS in my words, there's a lot of work, as I said before, to still be done. 50% is not an acceptable survival. We've got to do better. How are we going to get better? There's a couple of ways. One is expanding access of transplant to patients. So getting transplant to those patients that need it. The other is participating in clinical trials to try to figure out, where does transplant fit? Are there better medications and drugs that we can use or not? If you look at this graph, this is looking at the international registry. So every time we do a transplant, so if you're a transplant patient or a caregiver of a transplant patient, one of the things that your center should ask you is if you're willing to sign up to be a part of the registry. Please do it, because that really helps us to understand what's happening to patients that are getting treated for these different diseases going through transplant. And so this CIBMTR, this registry data showed that over the last decade at least, the utilization of transplant has gone up significantly for myelodysplastic syndrome. However, this was a cross-sectional survey done of physicians looking at what treatments were offered to patients for myelodysplastic syndrome. 58% of them just received a growth factor. Only 4% of those patients had a transplant or were offered a transplant. So that tells me I've got to do a better job as a transplanter of getting out in the community, meeting the community doctors and making sure they understand when transplants indicated, know that we're here, and maybe even try to bring some of my services to the community. I can't do a transplant maybe in your community, but I can see you in a consult and where your caregiver can come and hear the information about transplant and so forth. So I think there's a lot of this pointed out to me, there's a lot of work to be done still. And obviously, why aren't we doing more transplants? It's kind of what I was alluding to. There's provider and patient perceived challenges. So just kind of going through that list, the lack of awareness is probably number one. And a lot of times, societies like this are very important for patients to know that it should be an option. Because sometimes if you don't ask the question as the patient or the caregiver, it'll never get presented to you. So joining support groups, being a part of societies like this, people say, don't Google. Actually, I think it's good to Google because you might stumble upon a good organization to help you to understand your disease. So awareness of the indications and so forth of transplant are important. Knowing the provider perception, because there's always politics in everything that happens out there. And so in some cases, sadly enough, revenue goes to the top of people's minds. And so if I'm an oncologist in the community and I can give you chemo all day, that's revenue, and that's a tick in my hat with the administration. The fear is I'm going to send you to this transplant center and they're going to take over your care, and then I'm never going to see you again. And so that's lost revenue. So that's a very concerning thing for me. And so what I try to reassure the providers in the community is, number one, it's about the patient and them getting the best possible options. But number two, you're not losing that patient, because the reality is that patient we're hoping is going to be a survivor that's going to come back to that community. And then you will still have to help us in taking care of that patient after the transplant. So getting people over that mindset, I think, is helpful, or something we've got to do as well. Lack of care coordination. So across the board in oncology, that's a huge issue. Is, I've got an appointment to get a port. I've got to go over here and get this. I've got to see the transplanter. Oh, I've got a chemo appointment this day, so forth. How in the world do you keep all that, together? And so that's where the role of nurse navigation. In our case, with the transplant world, we have coordinators that are really kind of your go-to person to help make sure all of that's happening for you when you have questions. There's several financial barriers that occur. Probably one of the biggest, and the first step, is insurance. Insurance transplant is a whole separate benefit from your routine insurance. So there's countless times where I've seen that a patient can get treated by me all day with Vidasa, for example, but I can't do their transplant because their insurance says I've got to go to Mayo in Rochester. Well, now you've introduced travel as a barrier to that patient as well. So there's financial barriers. And then there's the lack of clarity around the post-transplant care. And that's where I say it's really about communication. So it's that communication back to the oncologist. So not just dumping that patient in the oncology office and them going, well, now what do I do? It's about that conversation of, oh, I need you checking counts once a week, or I need you checking this so often. Call me when, or if, or just call me if there's an issue. And then there's the patient-perceived issues. So one of the biggest ones I want to highlight is that we run into this issue of the caregiver. I think it's undervalued what a caregiver means to a transplant patient. The caregiver is really kind of your lifeblood because number one, I have to always remind patients, you have the immune system now of a baby. And so you've got to kind of be cared for like that. And it's hard for some people because you're talking about people who are adults who have been living their life and doing their own thing and not depending on others and so forth. And now all of a sudden I'm dependent on people. But it's critical because it's even that simple thing as being able to pick up the phone and call the transplant team and say, Mom doesn't look right today. I don't know what's wrong, but she doesn't look right. And 9 times out of 10, we're going to say, bring Mom in. But if you don't pick up the phone call, then it goes from Mom not looking right to Mom having a severe infection and then ending up in the emergency room and possibly losing Mom because no one was watching her. So caregivers go a long way in this journey. And the other thing I love about caregivers is they're going to tell what the patient oftentimes won't tell you. So a lot of times the patient doesn't want to tell you something because they don't want to go through whatever. They don't want to be admitted. They don't want to whatever. But, you know, Aunt Debbie's going to probably say, you need to tell them about this, or I am, you know. So caregivers go a long way with all of this. So several barriers that we have to overcome. The social barriers, I think we're getting a little bit better with societies like this, MDS and the Leukemia Lymphoma Society. There are several things out there, resources now. Even the pharmaceutical companies have resources for travel grants and other things to support patients through this process. So how do we improve? It's that whole circle of life, I call it. Basically, it's, you know, making sure we're communicating with the community oncologists. It's trying to work more with the government and the insurance payers to ensure that coverage is adequate. Some insurance companies actually in your policy will allow for travel and they'll reimburse you for that. If you have a cancer policy, don't forget about that. This is the time to engage in that. So, you know, working with the payers and so forth to improve the coverage for transplant, having more advocacy groups, I think is very critical as well, and having those in your community. The National Marrow Donor Program is also something that's where we get our unrelated donors from. And I'm going to show you the numbers in a little bit, but there's a striking difference between if you're white versus African-American in your likelihood of having a donor. And particularly of having a match. And so we've got to find ways to diversify that pool of donors. And it goes, I was shocked when I was working on this panel with the NMDP at one point, and I had no idea, but there are no registries in the continent of Africa outside of South Africa. Well, guess what? South Africa is a Dutch community for the most part. So the gene pool is different. So no wonder you're having a hard time finding donors for African Americans that are matched. The gene pools are different. So there's a lot of work to be done there. And then, like I said, trying to get the transplant center out of the center and into the community more is another big piece. And that's one of the initiatives that I have with the university as I start my practice at the Baptist Hospital, is that we want to get out to the community, do consults in the community so that way patients have access to us to ask the questions and decide, is transplant the right option for them? All right, now I'm going to shift focus to really the process of transplant. This gentleman, so E. Donald Thomas, the father of transplant, we like to call him, is the one who really discovered the ability to infuse these stem cells, and they magically find their way to the bone marrow, start nesting and populating and regenerate a new bone marrow. Amazing work that got him the Nobel Peace Prize. And so we think of two different main types of transplant, auto and allo. Auto transplants, or autologous, means self. So it's using your own stem cells. So we use that in diseases that are mostly sensitive to chemotherapy. And so you'll hear of that, a lot of times using diseases like multiple myeloma, lymphoma, those diseases that we know respond reasonably well to chemotherapy. But in our other diseases, we need something different. And so allogeneic transplant is what I call it's the OG, it's the original immunotherapy. So it's trying to use the immune system to help fight off any residual cancer that's there. And so there's terms you're going to hear kind of going down this blue boxes in the middle. You'll hear about the type of transplant that I just described. You'll hear about conditioning. Conditioning basically means chemo, and basically boils down to, are we doing intensive chemo, what we call myeloablative, or are we doing reduced intensity? Reduced intensity tends to be used more in your frailer populations and your older populations because the toxicity of the high intensity oftentimes is too much to be tolerated. And that's allowed many more patients to receive transplant. You'll talk about your donor type. In the case of the auto, it's yourself. In the case of the allo transplants that we're talking about today, they're either related or unrelated. And then the degree of match. So obviously you're perfectly matched with yourself, you should be, or else something's wrong. But then when it comes to an unrelated or related donor, you can either be fully matched, mismatched, or highly mismatched is kind of what that group we call haploidentical transplants now. And then the stem cell source that I mentioned before, we can get stem cells from the peripheral blood, and I'm gonna go through that process, or from the bone marrow, or even from cord blood now, which is where they have banked umbilical cords from babies after they've been born. And so we can now utilize those cells actually as a part of a transplant. It's more popular in the pediatric population than the adults, mainly because you have to have enough cells to do the transplant. And the dose of cells, the amount of cells we give is mostly determined by your weight. And so adults tend to be are heavier than children. And so you can use one cord oftentimes in a child, but you often need at least two in an adult. So cord blood use is going up. It's still not the predominant though that's used. So this is just showing you different indications for transplant. What I want to highlight is the blue with acute leukemia, so AML and ALL, and MDS and myeloproliferative diseases being the primary indications for allo transplant. As you can see, aplastic anemia and other types of leukemia also fall into that category. So what are our goals for bone marrow transplant in these two diseases? So in aplastic anemia, it's more about replacing the immune system because we think it's an immune issue. So we think your immune system, the patient, your immune system is actually causing the problem. So then we need to find a healthy immune system from another donor to give to you, which that's why you'll hear sometimes if, sister is a match, but sister has lupus, we might say, I don't know if we want her to be your donor because now you're giving him another autoimmune disease possibly. So that's what it's about in aplastic anemia versus in MDS, you're doing two things. Remember, this is a clonal disorder that's trying to become leukemia oftentimes. So you're trying to, one, replace the diseased marrow, but then you're also, again, trying to get the immune system of a healthy donor into your body so that therefore any residual cells that are left behind will be taken care of by what we call that graft versus leukemia or graft versus tumor effect that can occur. This is just looking at kind of the picking order. So obviously we try to get a matched sibling first. If we can't get a matched sibling, we try to get a matched unrelated donor, and then we start going to the alternative donors typically. Now this can change depending on your situation. So you could have something going on where you need to move to transplant now, in which case we might have to go with this haploidentical donor, which would be a half matched sister or a half matched child, as opposed to going with an unrelated donor that may take, the average turnaround time from when you see a transplant to doing a transplant is about 3 months. So, so if we can cut that time down by having a donor that's readily available, then sometimes we have to do that and accept the additional risk. This is just going back to what I described before of the degree of match. And so I like to think of as Mendelian type of genetics, basically. And so there's only about a 1 in 4 chance, so a 25% chance that any one of your siblings will be a match. So you can have 10 siblings. Each one of those 10 siblings still only has a 1 in 4 chance of being a match to you. So for that 70% or so that don't have a sibling as a match is where we turn to the National Marrow Donor Program. And that's where this issue comes up that I was mentioning before. So you can see from the NMDP data, if you're white, you have about a 77% chance of having a match out there. But if you're African American, only about a 23% chance. And then if you're Asian or Pacific Islander, about 40%, Hispanic about 40%, and about 56%, almost 60% if you're Native American. So, one of the answers to that is increasing the diversity of the donor pool. The other answer to that is what this curve over here, this study's tried to show, is utilizing more alternative donors. And so the blue represents having what would be an 8 out of 8 match, so a full match. And so if we look at this African-American population, for example, or the African population in general, you'll see this, like I said, about 20% having a full match. But if we take a 1 antigen mismatch, the red, so a 7 out of 8, now you're jumping up to almost 70% in some cases. And then if you add to that a 4 out of 6 or like a haplo match, then you start pushing up into 80–90%. So those are the things we're trying to do when it comes to working with the National Marrow Donor Program. One is diversify the pool so there's a better chance of raising this blue line. But then if we're not able to utilize patients that if we don't have a full match, utilizing and refining the approaches to treating patients and managing those patients with alternative donors, because there is a slightly higher risk there. So managing those patients effectively allows us to open up the opportunity to more patients. Okay, so this slide I like to use as a means of helping someone in particular who's going through the process. So there's always this dead time, so it feels, to the patient, I think, where it's like, I haven't heard from the transplant team in 2 weeks, or what's going on? So on the top is what's going on with the patient typically. On the bottom is kind of the stuff that's happening in the background with your coordinators and the transplant team. So the first step that starts this bottom part is the referral. So you have to have a referral from your physician, from your oncologist, to first get in the door with the transplanter. Once that happens, the very next thing that's going to happen is they're going to start looking at your insurance, because you're going to have certain benefits related to transplant. And what you'll find is you may be in network or out of network for certain facilities. So there could be a facility 2 blocks from you, but if they're not in your network, your insurance may say no. What we try to do in that situation is, particularly if you've been treating with me already, is get what they call a single case agreement. So we try to get your insurance to make an exception to the rule. But that's the first thing that's going to happen. Now, oftentimes, as we're going through that process, and particularly once it looks like the insurance is going to approve, or we know you already have an in-network insurance, then we start the donor search. And that'll oftentimes start with, if you have brothers and sisters, sending them kits. And so those kits, they can usually just do a swab and send it back in, and then we'll figure out if they're a match or not. And then if we don't have a match from one of your brothers or sisters, then we start moving to the unrelated donor database. And so once we've drawn your blood and gotten your type, then we can basically plug that into a huge database and see if there are any other matches out there anywhere in the world, actually. And so that donor search occurs. And then roughly around 30 days out, so within a month of your transplant, is when typically you'll come in and start doing what we call the pre-transplant evaluation. And so that's oftentimes a week or 2 of just going through the battery of tests, an echocardiogram, an EKG, all these tests that are basically trying to tell us as the transplant team that your organs are functioning well, and that there's no additional risks that we need to be thinking about when you go to transplant. And then as a part of that evaluation as well, we're also having you meet with a social worker, because we want to try to bring out any of those social issues that may be there, those financial barriers, for example. So we really dig in your business, because we need to know. Because the last thing you want to do is have a transplant, then come out and you don't have a caregiver, you don't have a place to stay. Guess what? You're probably not going to live through your transplant. Because the transplant itself, you're in the hospital and we've got nurses to take care of you. But when you get home, you don't. So we've got to make sure all of those pieces of the puzzle are in place before you even get there. And then the other thing is what's called a psychological evaluation. So Oftentimes, this is incorporated with the social worker, but if your transplant team, like your coordinator, your nurses that have been taking care of you, your physician, anyone on the team has maybe identified some issues of anxiety, depression, those are all things that become barriers when you get through the transplant, because you may be in the hospital for 2 weeks, you may be in the hospital for 3 months. So if you already have a tendency towards depression, we need to be prepared for that. You know, maybe there's some activities that we can have you doing that keep your mind kind of occupied and off of it. But that's very critical. And so I can tell you, we've even seen a patient that we thought we were going to lose because of severe depression. She got so depressed. Now, unfortunately, she couldn't help her situation because some other events happened, but she got so depressed that she got this thing we call, that's basically heart failure that occurred because of depression. So that broken heart syndrome is real. And so this lady went into heart failure. I mean, her ability, so your heart's supposed to pump out at least 50% of the blood that comes in. Hers was only pumping about 20%. So, and it was all emotional. It was nothing medical that was going on. So we've got to evaluate those things up front. So that's why it's such a rigorous process. And then after that comes the admission to the hospital. And then the duration of the admission really depends on, obviously, how long it takes you to recover from the transplant. CVC, meaning central line. So we tend to give the stem cells and the chemo through a central line. So that usually gets put in during admission. Conditioning is usually about a week of chemotherapy plus minus radiation. And that's basically to prime the marrow, if you will. So make space for your donor cells. And then the actual stem cell infusion is what we call day 0. So that's your new birthday, basically. This is another way of depicting the same thing, but now capturing the post-transplant phase. And so after you have been transplanted, I actually like to use this graph because this tells you what your milestones really are. So after the transplant, so you get conditioned, you get the transplant, which is the infusion of the cells. Then it's waiting for this term called engraftment. And engraftment is basically meaning the cells have taken hold. We know that the bone marrow is regenerating like it should. And we base that on your blood counts. And so we're looking at your neutrophils. We want those to be over 500 and your platelets to be over 20,000. And then along the way, there will be some complications that we'll talk about here. And then after you engraft, there's other complications we have to worry about as you go through this whole recovery process. So what does a truly recovered transplant patient look like? So it means their performance status is improved, their blood counts are back to normal, essentially. You've been able to taper them off of the immunosuppression that they're on. And then they're basically in the phase of either being on maintenance therapy or just being surveillance for potential relapse of the disease or complications. What I use as a gold standard is that person back to work, or is that person back to what would be their normal life again? And sometimes it's a new norm, which is what Dr. Goorha is going to probably talk a little bit to you about as well. So real quickly, how do we collect the stem cells? 2 ways. We can either collect them through a harvest, and that's what I was telling you is in the operating room. Typically, you'll have 2 physicians in there, one on either side. We're using those similar needles to what we do a bone marrow biopsy with, and we put a needle in, we draw out about the amount you see in that syringe, so about 10 milliliters of marrow, and we put it in one of these bags. And then you take the needle out and you do it again. And you keep doing that until this bag fills up to the point that you've got enough cells. Usually that's going to be about 1 liter. So you think about it, you're taking about 10 milliliters at a time to get to 1 liter worth. So it can take a while to do that. Peripheral blood stem cell collections become the more commonly used way, which is where you're basically getting a series of shots called Neupogen. That's moving the stem cells out of the bone marrow into the bloodstream. And then once they've moved into the bloodstream, we can connect you to what's called an apheresis machine, which is basically like when you donate platelets. And so what it's going to do is it's a fancy centrifuge. Basically, your blood goes in, it spins it around, you separate it off and take off the buffy coat, which if you back to your basic science, that's the white blood cell layer. And within that layer is where you have your stem cells. And I wish I had been the genius that figured that out. I mean, it's so simple, but yet so amazing. And so this just shows you that over time, we've really moved to, in the green, more and more utilization of peripheral blood cells and less of the bone marrow as a source. Now, my colleague in the other room will probably go the opposite way. They tend to use more bone marrow in children versus peripheral blood in adults. All right, and then stem cell processing. So once those cells are collected, they're going to go through a process of being sorted into counted and sorted and so forth. If it's from the bone marrow, we've got to filter them. So all of that's done in your stem cell therapy lab. And then in some cases, we freeze those cells and store them in a liquid nitrogen tank for later. In most cases of what we're talking about in allo transplant or transplant from a donor, we want to try to give those cells fresh. So usually they're getting collected like the day before you're actually going to get them. Or in some cases, if it's within your own facility, they're being collected and given in the same day. So, so there's sometimes a storage process. This is day 0. And I think it's a surprise to a lot of people. There's no sticking needles in a bone or taking a bone out and putting another bone in. It's none of that. It's just like getting a blood transfusion. And actually the complications of the infusion itself are very similar. So you can have fever because there are some red blood cells in there. If there's incompatibility or mismatch of the A's, B's, and O's, then you can get a reaction at that time from that as well. And then there's the preservative. If it's a frozen product, they can also cause some issues called DMSO. And then I'm just going to wrap up with the main complications of transplant that we look for. So they typically are divided into early and late post-transplant care and complications. So early on, most of what you're going to see, particularly in the first month, are complications of the chemotherapy itself. And so that's the mucositis, which is the irritation of the lining of the mouth and the GI tract. So that's where the diarrhea, the nausea, the mouth sores, things like that come into play. VOD or hepatovenoocclusive disease is a rare condition that we can sometimes see. It presents essentially as your stomach starts swelling because you're starting to develop fluid in your abdomen. So it kind of looks like someone who has cirrhosis, but it's quick. And so there are treatments that we use for that to reverse it. It's essentially blockage or clotting of those blood vessels going into the liver. And so you create this back pressure and fluid filling up in the abdomen. And so we have to move on that very quickly to treat that. And then this idiopathic pneumonia syndrome is a whole spectrum of things that we can see, which is basically different types of non-infectious pneumonia. And then infection, so inflammation in the lungs, essentially. And then there's acute graft versus host disease. We call it acute when it occurs within 100 days of the transplant. And then there's infections, obviously, and then the low blood counts that you have to recover from. The late care really gets into more of the low blood counts that linger. And so you will see that oftentimes. Some people will be 3-4 months out and their counts are still not quite normal. Some of that depends on the degree of match. Some of it depends on what you received as your chemotherapy and conditioning up front. So there's a lot of what your underlying disease was. So a lot of variables go into that. And then there's the chronic graft versus host disease, which I'm going to show you a picture of that as well, which is basically occurs after 100 days. So if it's less than 100 days from transplant, we tend to call it acute graft versus host disease, and it tends to have a little bit different presentation from the chronic that occurs after 100 days. And then the rest of your time is really spent on reconstituting your immune system. So acute graft versus host disease, this is a couple of pictures looking at someone's skin. Oftentimes the most common thing we'll see is a milder case of kind of a red irritated skin, but it can get to the point that it looks like almost like a burn victim where skin is peeling off and so forth. And so that's what we would call a grade 4 or severe graft versus host disease. This is looking inside someone's colon, where you can see that here they've got some little patchy areas of irritation. So that's that inflammation of the GVH. Versus now actual parts of the colon cells are dying off. And so that's the more severe version. And those patients have just florid diarrhea basically, and sometimes blood in the stools and pain in their abdomen as well. The graft versus host disease can affect your liver as well. And it can also affect, you can get anything from a rash to blisters on the skin. The chronic, on the other hand, for the most part, the most common thing you're going to see in chronic is going to be skin and joint manifestations, and potentially this down in the corner. So those ulcerations that are kind of like cold sores inside the mouth. And so you can see that as part of chronic graft versus host disease. But the skin changes are very different in chronic versus acute. In chronic, we tend to see things that look more like almost like psoriasis. And then they tend to get more stiffness. And so it's kind of the stiff man syndrome. They gradually go from being able to do this to, I can do this, and then next day I can only get my arms up like this. And it has to do with the fascia, the lining around the muscles that's getting tightened up. And so you can see a number of those effects with chronic graft versus host disease. The infections tend to occur in phases. This is a complicated diagram. The bottom line is that your immune system recovers in phases. And so in the first phase, you're more prone to bacterial infections because those are the cells that aren't back yet. Then once those are back, you've got to develop the cells that are going to basically help you fight off more like viruses. And then you've got to develop that memory again, which gets into your vaccinations and so forth later on. And then lastly, these are other late effects. The one I like to, this slide right here is really what survivorship is really about. So it does me no good to cure your MDS and then you die of a heart attack. You know, so you have to pay attention to all those things. So that's where I tell my transplant survivors, it's very important that you still have a primary care doctor. I don't care if you're seeing me every month or every 2 or 3 weeks. You still need a primary care doctor that's going to look at those issues of, is your hypertension controlled? Is your cholesterol controlled? Those things that put you at risk for the cardiovascular disease. So, and then the metabolic syndrome obviously is a real big problem in the US in general. That's obesity and just basically not eating right and not exercising and being healthy. And so that's something we've really got to work on with our survivors. We believe that not only plays into having more complications of the therapy, but also plays into, in some cases, we've proven into risk of relapse of diseases. So very important things. So I'm going to now turn this over to Dr. Goorha. I think he's going to talk more about life after transplant. Thank you. Oh, right down here.
All right, well, thanks to Dr. Randolph, thanks to Lee and Dr. Thoda for having me here today, and I'm honored to be here talking for the AAMDS. And what I'm talking about is living well during and after transplant. As stated before, I'm the director at the Baptist Hospital for the Malignant Hematology and Transplant Program. Just a conflict of interest disclosure, which is really, I don't have any. And if anybody wants to use these slides for any purpose, I'm happy with that. So I'll be talking about living well. What does it mean? And part of that is obviously in the context of a transplant. So I'll be talking about complications and effects of transplant, management of side effects and stress, and then kind of what Dr. Randolph was saying, after the transplant's over, what can you do to improve your life and to live well? So I'll be trying to give you some tips on that. So the first question is, what is living well? So this is one of those situations where I had to, when I was making the talk, it was pretty tough because, we, as doctors, we like to think scientifically and about science. And I think this talk, I had to think more of as a patient. And what does that mean? So to me, what is living well? Living well to me is taking care of the mental, physical, and spiritual aspects of your life. And I think, as I said, the key for me to make the talk was, what are the things as a patient that you can do to improve the quality of your life or improve your life? And so when I think about what living well is, I think it has 3 components. One is the mental aspect of things. Obviously, when you go through a transplant, you're affecting the physical aspect, your body, and your things in your environment. And then the spiritual aspect, obviously, is sort of the center of everything. And so I think addressing all of 3 components is important to living well. So the spiritual is the first thing I'll talk about because it's probably not my expertise. So, but I think it's important to talk about it because looking at this part of your life it affects everybody, and it's going through something like a stem cell transplant or any kind of serious treatment like chemotherapy. It's obviously something that people will be thinking about. And so the spiritual matters. I think and the way I look at it is there are certain questions that you'll think about, like, why is this happening to me? What is the meaning of my struggle here? And how can I find joy and purpose in life? And I think thinking about, I don't have the answer to those questions, but I think thinking about those questions, it's important to acknowledge that those are important questions that we all have as we're patients, and especially if you're going through something like a transplant. So I always think about this prayer for serenity prayer. It's one of my favorite quotes. And I thought about it in the context of this talk and what living well is transplant. And the prayer for serenity, if you don't know it, is, God, grant me the serenity to accept the things I cannot change, the courage to change the things I can, and the wisdom to know the difference. And that was by Reinhold Niebuhr. So the reason I think this is important is, and it sort of kind of shapes the talk, is I think as a patient, there's certain things that you have control over when you're going through something like a transplant. And then there's plenty of things that you don't have control over. And that's some of those things that you don't have control over. That's what your doctor is for. So I think the way I tried to gear this talk is to kind of focus on things that as a patient you may have control over, so that you can affect those things to improve the quality of your life. I will talk about, and I think Dr. Randolph kind of covered some of the bases, so I don't need to spend that much time, about some of the complications of transplant, because I think it's important to mention. But I think the focus of the talk is really what can you do to improve the quality of your life going through a transplant. So similar to what Dr. Randolph said, there's certain complications that we see commonly in patients undergoing a transplant. And so when you go through the transplant, the first thing you get is chemotherapy or medicines to help prepare your body for the transplant. And those medicines can have effects causing mouth sores, or what we call mucositis, or nausea, vomiting, diarrhea, the GI problems that we see after transplant. They can injure your organs, such as your liver, as we discussed. And obviously, these treatments can have side effects on your blood. And so these are things that are very common that we see after transplant. Obviously, we see infections, and then, as Dr. Randolph mentioned, graft-versus-host disease. So this is sort of the timeline, in the first sort of 1 year after transplant, seeing these early on, the GI side effects of the transplant. As we go on, we see more of the liver and the infection problems. And then as we go on, we see more of the chronic GVHD, while the acute GVHD is in the first part. These are the long-term late complications of transplant. It's a very busy slide, so I'm not going to mention everything, but it's just important that it can affect all the major organs in your body. So we can see psychological effects, depression, anxiety. It can affect how you think, how you process information, so cognitive effects. We can see effects on the lungs with graft-versus-host disease of the lung that can manifest itself in different ways. Effect on the heart, obviously, kidneys. We see iron overload problems. We see a lot of patients who get chronic osteoporosis from the transplant. And then, we talked about diabetes as well, metabolic syndrome. We can see effects on different organs, including the mouth, the breast, the thyroid gland. Obviously, heart disease, we talked about liver disease, and then your sexual health and your fertility is also affected. So these are some of the infections that we see. I'll go into a little bit more detail about that. And this is sort of the timeline of the recovery after the transplant. So what the things that we see that affect the incidence or the nature of the side effects after transplant are your age, what other diseases that you have, what kind of support systems that you have, the type of chemo that you got, and obviously if you get graft-versus-host disease. In the early part of the transplant, we see a lot of, obviously physical effects, fatigue, problems with your sleep. Sort of later on, as you're going through the initial recovery, there's some psychological effects, like Dr. Randolph mentioned, depression, anxiety. And then later on, we look at more sexual side effects, sexual function, and then how to integrate yourself back into society, your role, your social, your integration back into the world. And then we already kind of discussed, I won't spend too much time on GVHD, But just again, it's a major complication after allogeneic transplant where the donor cells may not recognize your body as their own. So they start attacking your body and causing organ damage. And we saw that we have acute, which is the type of GVHD that tends to occur early in the transplant, and then chronic, which occurs later. And depending on how it affects you, you can get one or both of those types of GVHD, and it can be mild, moderate, or severe. We saw some of the same pictures here that where it affects your skin, your intestine. This is just a slide showing that this area right here is a lot of swelling in the skin that should not be there normally, and it's being caused by GVHD. As we can see, the chronic GVHD can affect your joints, causing you to kind of be stiff like this person looks, ulcers in the skin, and problems in the mouth and the lungs and the eyes. So the way we treat GVHD is with immunosuppression, with steroids, and these are medicines that are used that can also increase the risk of infection. Sometimes we have to do intense treatments in the hospital. The main thing I wanted to point out with this is that over the past 2 years, we've gotten 3 different new medications to treat GVHD. So and over the past 20 years, I can say we probably haven't had any new medications. So it's really exciting to see some real progress on this front in terms of treatment of GVHD. So one of the complications of transplants that's very common is the stomach problems or GI problems, nausea and vomiting. And just a definition of nausea. Nausea is a feeling queasy, sick to your stomach, an unpleasant feeling that you have. Vomiting is actually when the inside of your stomach goes through your mouth to the outside. It can happen together, or they can happen one without the other. Any side effect that can make eating or drinking difficult increases the risk of health complications and a poor quality of life. So obviously, in transplant, we use a lot of medicines to prevent nausea and vomiting, but as we all know, those aren't 100% effective. So these are some other tips that I think people can use to help manage nausea through a transplant or any type of strong treatment like chemotherapy. So eat small meals during the day, throughout the day, separated out. Eat bland foods, crackers, toast, cereal. Avoid foods that you know may trigger nausea, fried food, spicy food, strong smelling food. People have noted that things like the ginger spice in ginger ale, for example, can help relieve nausea. It's very important to drink plenty of fluids and water to avoid staying dehydrated. And then we recommend sitting up after a meal to allow the food to come down and digest. Avoid skipping meals because an empty stomach can make nausea worse. Wear loose-fitting, comfortable clothing. And there's certain therapies that we're also looking at: acupuncture, massage, deep breathing, hypnosis, meditation to help relieve nausea. So it's non-medical or non-drug related treatments. Sorry. And then one of the major categories of complications after transplant is infection. So important to know what the signs of infection are: fever, chills, sweating, abdominal pain, diarrhea, burning when you urinate, severe cough for women who get a vaginal discharge or itching, redness or swelling around a wound or a catheter site, and bleeding gums, white patches in your mouth. So tips for preventing infection: washing your hands is probably the number one thing. That's for doctors too. Eating, especially after you eat, and go to the bathroom. Use hand gel or liquid hand sanitizer if soap and water are not available. Making sure to maintain good hygiene, taking a bath every day, shower or sponge bath if you can't take a shower. Taking care of your nails, keeping them short. That's a good way to spread infection, is with long nails. When your blood counts are low, it's important to use an electric shaver instead of a razor to prevent cuts, which may form sores and lead to bleeding and infection. To use extra soft toothbrush to avoid trauma on your mouth, which can lead to infection. Keeping your port or catheter clean. It's important to keep your rectal area clean after each bowel movement. We see a lot of infections in the lower skin around the rectum because of poor hygiene, and it's important to avoid that if you can. If you have irritation or hemorrhoids, please mention that to your healthcare provider. Especially in the era of COVID, it's important to avoid crowds. If you have to be in a crowd, wear a mask. Avoid people who have colds or flu or measles or chicken. Anybody who's sick, you need to avoid them. If you're cleaning up after young children or gardening, it's important to wear gloves. You shouldn't be cleaning up after pets, but if you are, wear a mask and gloves. Avoid activities that put you at risk for cuts, burns, and other injuries. Again, wash your hands, wash your food, especially raw fruits and vegetables. Try to cook your food as soon as possible so it doesn't sit and get bacteria growing in it. Be very careful when you're eating out, to be careful that the person you're getting your food from they maintain a clean environment. I definitely tell my patients to avoid buffets because that's a really popular place to get a foodborne illness. Salad bars are as well. And then avoiding raw foods such as sushi, pre-made foods at grocery stores. When they sit for a long time in the grocery store, they're a source for infection. Raw eggs and cookie dough. And if some people have to use the water from a well, but if you do, make sure you test it and boil it. So one of the things I think people don't talk about a lot in sort of scientific discussions is the financial issues that come up with the bone marrow transplant or stem cell transplant. And so it's important, I think, to note that there's some major financial issues, and it's because it's a very expensive procedure. And a lot of the costs will depend on, where you go for your transplant, the type of transplant that you have, the length of your hospital stay, and then any complications that may arise during the process. So it's important to plan in advance how your medical and routine expenses will be covered while you undergo treatment. It's important to note that you have out-of-pocket expenses like deductibles and copays, and you have to plan for that. Prescription drugs, wigs, medical devices may not be covered by your plan. What we see a lot in our clinic is the need for dental work, because dental infections are very common. It's important to have your teeth in as good a shape as possible, and a lot of insurances don't pay for dental work. And then so we have people in our program, and there are people around you in the hospital and in different services to help with these financial issues. Financial coordinators, pharmacists. Our pharmacist spends a lot of time finding drug assistance for our patients. Social worker, that's kind of their job to help manage the out-of-pocket expenses. And then when you're going through the actual transplant process, there's a case manager your insurance company may assign. They can help you as well. It's important. This is something that we see on a daily basis with our transplant patients. It's important to organize yourself financially. So find out who's going to pay your monthly bills. You don't want to fall behind and lose your power or lose your apartment where you're staying. Who's going to manage your health insurance? Who will pay your taxes? Do you need to make special arrangements to pay your bills? So you don't. If you plan ahead, you won't fall behind on your bills. There's a resource I found on BMT InfoNet that helps identify places to go to find financial help for transplant. And additionally, we have funds in our program, and I suspect most transplant programs have funds to help their patients get through some of these financial issues. Another aspect of one of the three aspects I mentioned initially is the mental health. So it's important to note that mental health is important. Depression, anxiety, stress can take a toll on your physical health. And obviously cancer treatments such as chemo and strong medications and radiation that we use as part of your treatment can affect your thinking and affect how your concentration, your memory, your ability to multitask. And most patients, especially the ones that we see, what we put through the strong therapy, can have major or significant cognitive effects. Usually they only last for a short time, but sometimes they can persist, and we have to address them in a different way. Memory problems, examples of what I'm talking about: memory problems, forgetting where you are, things that you normally would remember, difficulty finding the right word, difficulty processing your thoughts quickly, trouble understanding what people are saying, difficulty following instructions, difficulty learning and recalling new information. And so some tips to manage these effects, the cognitive effects on your from transplant or from chemo, is to take notes every day, write to-do lists, use a calendar, a daily organizer, or a mobile app to keep track of appointments, activities, and important dates. And as I'm reading this, these are things I do normally, and I'm not a transplant patient. So obviously these are important skills to have as you get older. Organize your home and workspaces to make sure everything's in place. Get rid of clutter, do one task at a time. Avoid multitasking, minimize distractions such as your cell phone when working, exercise your brain. I see a lot of my patients doing crossword puzzles, and that I can tell will help help them in the long term, maintaining their cognitive function. Painting or journaling can help. Exercising is always a good effect on your brain as well. Avoiding alcohol and other substances that alter your mental state. Managing stress, taking care of your mental health, relaxing, learning how to breathe or meditate if that helps you. Ask for help. That's a big thing. You have people who are around you who are there to help take care of you, and it's important to be honest with them so that they can help you remember things and complete tasks. And then try to reduce stress by doing things that you enjoy spending time with, like your family, hobbies like doing things outdoor, gardening, journaling, reading, meditating. It's important that if you're feeling anxious and depressed, to talk to your providers, because they can help you, and they can we can refer you to a professional counselor. We can start you on medications to help with these feelings as you go through your transplant journey. So the last part of my talk is just ways for managing your long-term health. And these are what I call healthy habits for living well. And so it's important to develop healthy lifestyles and habits so that, like Dr. Randolph said, the chronic problems that we see are not that different from people who don't go through transplant, like heart disease, diabetes. And these are things that affect people who go through transplant maybe at a higher rate. So we have to be more aware of them and more aware to how to deal with them. So during cancer treatment, these habits can help you manage side effects and decrease the risk of complications such as malnutrition and infection. After transplant, these healthy lifestyle habits can help you recover faster and decrease the risk of other cancers, heart disease, and diabetes. So nutrition is always an important factor in your health. So nutrient-rich foods give your body the fuel it needs to function in a healthy fashion, and it helps prevent disease. Good nutrition also supports a healthy weight, which prevents other major problems. Based on the American Heart Association recommends a plant-based diet with a variety of fruits and vegetables, whole grains, healthy fats such as olive oil, avocado, and nuts and seeds, and avoiding animal fats. The American Association of Cancer Research recommends that 2/3 of your food on your plate should be vegetables, fruits, whole grains, and beans. So that's important to note. The physical activity is another healthy habit to maintain. So the benefits of that include weight management, increased energy, increased mobility, better mood, and a decreased risk for disease. And the American Institute of Cancer Research recommends getting at least 150 minutes, about 20 minutes a day of moderate activity, such as walking, swimming, stretching, yoga, and 75 minutes of vigorous activity. Obviously, as our patients who are in the first part of their transplant journey are not able to do these, but it's something as you get healthier and feel better, important to work on your exercise. And as you do that, you may want to start slow. You start slowly and then slowly, gradually increase. And then if you have problems with mobility, we refer those patients to the physical therapist. These are sort of obvious, but maybe very important to highlight, is avoiding tobacco. Smoking increases the risk of a number of cancers. It makes complications of transplants more severe. Even smokeless tobacco can also increase the risk of cancer. E-cigarettes do contain chemicals and substances that can cause lung damage or other organ damage and possibly cancer. Alcohol intake, we see obviously in overuse or abuse of alcohol can lead to major problems, including liver disease, pancreatitis. What we see a lot is alcohol can interact with a lot of medications that we put people in the post-transplant setting on. And so it's important to avoid alcohol for that reason. And this may seem like a minor one, but it's important to use sun protection. A lot of the medicines that we use after transplant increase sensitivity of the sun on your skin. And so it's important to avoid the sun, avoid direct sun when possible, use big hats, wear a broad spectrum sunscreen, SPF of 30 or more, wear protective clothing and sunglasses to help protect your skin. So hopefully I've kind of highlighted some of the mental and physical and spiritual aspects of transplant and how they're involved in after the transplant, and how do use the awareness of those factors to live well. That was the purpose of my talk. I think the way I wanted to end the talk was that some quotes I found from blood cancer patients that I thought were relevant and actually inspiring. And so some of the patients said, stay strong and keep moving forward, find the positive in every day, be your own best patient advocate, accept, learn, focus on the present, learning to live a different life, patient, present, positive attitude, hope, and faith. Test to test, I will survive. I don't look forward. I don't look back. I only look forward. Meditation, mindfulness, wellness, faith, nutrition, and optimism. Finding the joy while living with uncertainty. Blessed to do so. Blessed to be doing so well. Eye-opening, needed learning and healing. Watchful waiting can be watchful worrying. So sometimes not everything is positive after a transplant. Scary and expensive. Grateful, blessings, hope, and faith. Thank God for stem cell transplants. Extraordinary, grateful, I love my life. Diagnosed, frightened, tested, treated, waiting, and hoping. I'm more generous and patient less often. Embrace your treatment day after day. Strength you never realized you have. Challenging to our minds and hearts. And my favorite one is the end. Life is what you make it. Live life in a beautiful way. So that's my presentation, and we'll take some questions now.
Thank you so much, Dr. Randolph and Dr. Goorha. So we'll go ahead and we'll do, we have some questions online, and we'll see if we have some questions in the room for you both as well. So our first question is, what is done to prevent GVHD?
Either of us can talk about that. So a couple of things. I think, from our medical side of things, there's medications that we use for that, generally classified as immunosuppressive drugs. There are different regimens or protocols that are used, and that's actually something that's still being investigated, is what is the optimal protocol for various situations. So that's still being sorted out. I also think, as Dr. Goorha kind of pointed out as well, there's some practical components to it on the patient side. The way I like to think of it is, once you've had a transplant, anything that's going to cause an undue stress to an organ is probably a risk factor for developing graft-versus-host disease. So that's the whole purpose of the sunscreen and staying out of the sun. You think about it, what does the sun do? It stresses the skin, and therefore those immune cells are going to go try to do what they're supposed to do in the skin, but then they get overactive and cause graft-versus-host disease. So there's the medical side of things we do to try to prevent it, but then I think there's also kind of the practical things day to day. Yes, and then obviously the degree of match to your donor plays a role in your risk as well.
I have a question, Dr. Randolph. The cord cell transplant bank or whatever, is cost a problem with that? It's very costly to keep those refrigerated. Is that the
That's
issue?
a good question. I myself have not been involved with a cord bank, but having trained at MD Anderson, they are very engaged in it. The issue is there is cost, but there's also the quality of the bank is an issue as well. Some of them are more responsive than others, and then the quality of the cord that you get can be different as well. So one of the things I've always encouraged, I personally don't do cord transplants because I think you need to have a lot of experience with it to know what banks are good and what banks aren't. So I typically refer patients to a bigger center that does it on a regular basis, if that's the option that I think they need.
Thank you. This question says, thank you, Dr. Goorha, for mentioning about cognitive concerns after transplant, chemo brain. Does the type of chemotherapy given before transplant increase a patient's risk of developing cognitive disabilities?
I think the first way I would respond to that question is we don't know. And one of the problems with the cognitive effects of chemotherapy in general is there hasn't been a lot of research on it until recently. And so we don't know a lot of what we need to know about that particular complication. I would say, yeah, after I would say I don't know, I would probably say that it makes sense that it would make the type of treatment would make a difference in the type of complications maybe some of the more intensive treatments would have more of a cognitive effect, but I would still go back to fundamentally, we don't know the answer to that question, and it's something that we need to research more.
Second part to that question is, should patients receive a cognitive baseline prior to receiving chemotherapy in preparation for transplant?
I think that's a good idea. I'm not sure that we're, as a as a transplanter, would use that information in a very helpful way because of how little we know about the cognitive effects of therapy. But I think it's a good idea.
Thank you. Our next question
go ahead.
is,
If I
what
can
are,
tag on to that.
go ahead, Dr.
too, I
Randolph.
think that's something that is being looked at as well in the broader context as well, because the other population is the geriatric population or your older patients. And so there are people doing, you may have heard something called ERAS, so you're an older person going to surgery and they're worried about your complications and your needs to have opioids and things like that for your pain. So there are actually groups out there now starting to study, what if we do a full geriatric evaluation on your patients over a certain age, and we identify early what their risks may be and start working early with physical therapy or early on the cognitive impairment, things like that. Can we overcome some of those barriers? But again, that goes back to my point of looking for those clinical trials, or when they're available, participating, because that's the only way we're going to really learn what to do.
Thank you. Our next question is, what are the risks to the donor in the process of a bone marrow transplant? Looks like a lot of bone marrow being taken out of the donor.
Yeah, well, for the bone marrow donor, we probably have not involved as maybe as other institutions in doing bone marrow harvesting or taking the cells, but as Dr. Randolph mentioned, there is a risk because these patients need anesthesia, and anytime you get anesthesia, there is a small, maybe smaller risk as we get better at it of complications. When you're doing that many bone marrow aspirations, there's obviously going to be some pain afterwards. And so that's a complication. There's obviously going to be a risk of infection anytime you put a needle into anything. I think some of the more rare complications that I've seen are nerve injury and the chronic problems that can, or not chronic, but problems that can arise from hitting a nerve during surgery. And there's certain techniques that we use to avoid that, but it's not always possible to completely avoid that. Those are the complications I can think of. But
yeah, I agree. A lot of it boils down to it's just like a surgeon. The experience of your surgeon really matters in that situation. And so I've been involved in doing a lot of bone marrow harvest, and we harvest for the parents of children at St. Jude's as well when they need that done. And so the more you do, the lower the complication rate generally. Generally speaking, if you're doing a bone marrow harvest, though, because it's a healthy donor, you don't tend to see really problems with their blood counts. It's more physical issues. And so the soreness around the pelvic area, which we can inject local anesthetic now, we found will decrease some of that. And most people, that soreness is gone within 2 to 3 days. So really not bad. You may have heard of the National Marrow Donor Program. I happened to actually be in Minnesota when the news came about this one donor that passed that was donating bone marrow. And I can tell you how much of an upset that was for people. But it turned out that it was the anesthesia risk that was the problem. It wasn't the procedure itself. And so that patient had significant cardiovascular risk and actually died of a heart attack from the induction of the anesthesia. And even going further, it was interesting that we learned that patient had been declared not to be a donor, and then but insisted that he was going to be a donor. So, so I think overall we see very few complications with bone marrow harvest, and much less with peripheral blood. Peripheral blood collections, the main thing you'll see is a temporary dip in your blood count, particularly your platelets. You may, it can cause the calcium to run a little low for a while. So some people get a little tingling and numbness around their lips, but that give them a couple of Tums and that goes away. And so those are the main things. And then afterwards, people tend to tell me they feel a little tired for a day or two. And I think that's just the whole stress of the situation and the shifting of blood. But overall, we found these to be relatively benign procedures.
Thank you both. Our next question is, will a transplant, if successful, cure all other autoimmune conditions a patient may have previously suffered from?
That's a tricky question. I've tested that theory with patients with Crohn's I've had. So it can, and in fact, there are transplants being looked at. It's being looked at to do transplant for certain autoimmune diseases. The issue is that there's a higher risk in that patient going through the transplant of complications. So that's what we're trying to figure out is how do you weigh the scale of risk benefit for those patients? Because theoretically, yes, that could get rid of the other autoimmune diseases.
Thank you. Dr. Goorha, you had mentioned about diet and being mindful of infections. How long does a patient need to be mindful about the types of food that they're eating after transplant?
I think the first thing I'll say is that this is something that's changed in the last couple of years, in the sense that when I was doing my training, we were a lot more careful about diet than we are now, because what we've learned over time is that the actual risk of infection through your food is pretty low. And we don't want to restrict too much. It's more important to maintain a good nutrition rather than being restrictive on the types of foods you eat. That being said, there are risks, and especially with sort of raw foods that can give you bacteria. There's not generally speaking, that we say that 3 months after the transplant is the main risk period for when to be mindful of the diet. And I think more acutely, the actual month after the transplant, when your blood counts, the white blood count especially, is very low, that's when the major risk is. So what I find is, as I'm talking to patients as they progress along after the transplant, we liberalize or make their diet more open the farther they get away from the transplant. But there's also mitigating factors, like if you're on a lot of drugs to suppress your immune system, then maybe even after 3 months, it's not safe to eat or to go to a buffet, for example, which I probably wouldn't recommend to any patient in the first 6 months or year after the transplant. But I think the first 3 months for some things in the diet in the first month for maybe is where we sort of put some marks down about when the diet can expand.
Thank you. The next question is, it says, I recently had a transplant and I'm doing well. I had 2 donor options, a male and a female donor. Why did my medical team choose the male donor? Is there a preference of male donors over females?
There is, and some of it boils down to the amount of pregnancy. So women, when they bear a child, they tend to develop more antibodies, and those antibodies will oftentimes predispose you to graft versus host disease. But even just from a statistical perspective, when a male donor receives a female donor graft, the risk of graft versus host disease complications is higher. That's just by the statistics, regardless of the science. So that would be the reason we do tend to prefer a male. So in order of preference, when we're looking at donors, it really depends on your individual situation, but generally speaking, a young male is the ideal candidate if they're a full match. If you're both matched, a young male. And then we start looking at all these other factors as far as like CMV and other things that are there about the donor.
Thank you. Our next question is, does TP53 complicate a transplant?
The short answer to that is yes. The reason is that so as a background, TP53 is a genetic mutation that occurs in the bone marrow of patients with diseases like myelodysplastic syndrome and acute myeloid leukemia. And So it's one of the tests that we test for when we do a bone marrow biopsy is to look for a P53 mutation. And the reason it can affect the transplant is that the studies that have been done looking at P53 or TP53 mutation seem to indicate that the patients that have that mutation don't seem to benefit much from a transplant. And so we're sort of very careful about taking patients to transplant with P53. Now, some of those studies are what we call retrospective, meaning they're looking backward rather than looking forward. So they may not be perfectly indicative of the reality of the risks with P53 mutation, but sometimes that's the only data that we have, and making decisions based on that is all we can do. So that's I think maybe you would.
Yeah, I agree. And the other issue is that the other issue is that the data lags behind now. So our conditioning regimens and our protocols and all have evolved over time, and a lot of that is data that's looking back retrospectively. So, but yeah, it really depends on who you ask. It's still a very tricky question. We know those patients don't do as well. The question is still, how much benefit is transplant in those populations? And we don't really, in my opinion, I don't think we fully understand it yet.
Well, thank you both, Drs. Randolph and Dr. Goorha, for spending your time today and talking about transplant and GVHD, sharing your time and your expertise with everyone today. And if you'd like to watch the session again at a later time, it will be available on the conference platform within the next hour by accessing the session, clicking on replay, or navigating the on-demand tab in the platform hub. If you have any additional questions, you can send it to us at any time in 3 ways. Send an email to help@aamds.org, call our helpline at 800-747-2820, or submit your question to our Facebook page. If you're watching online, please do take a few minutes to complete the session survey. Your input is important to us and helps us plan our future programming. There's still time to visit the exhibit hall and chat with any of our conference sponsors. This concludes our conference today. And again, I'd like to thank all of the staff that took the time to come out today and answer all the wonderful questions from our participants and sharing their time here today with everyone. I'd also like to thank all of our corporate sponsors who supported the conference, came out today to be part of the conference and be with all of us. So thank you to everyone for a wonderful conference. And thank you to Dr. Swapna Thoda, who worked with us for months, putting together an excellent team of physicians to help educate our patients and their family members. We're eternally grateful, and thank you so much for being such a big part of our AAMDSIF family. Thank you again. And on behalf of the foundation, I'd like to thank everyone for joining us, always making us your resource of choice for information on bone marrow failure. Our medical advisory board and team are always here to support everyone and their families, as we've done for the past 39 years. This concludes our conference. Thank you again, everyone.